Today we are going to talk about PCOD, Polycystic Ovarian Disease. The incidence of this disease is 10% among the all reproductive age group ladies. Features of the disease is primarily anovulation, androgen excess, obesity, infertility, and increase in luteinizing hormone, that is LH. The PCOD is characterized by two things basically. There is a minute cyst in the ovaries. You can see here, this is ovary, and there are very small cysts, multiple cysts are available. Plus there is a hyperandrogenism. Now coming to the pathophysiology of this disease. Now coming to the pathophysiology of this disease. Basically what happens is there is increase in LH that will lead to stimulation of the ovaries. That will be much stroma cell and theca cell growth, and that will eventually produce androgens. Some of this androgen will convert to estrogens through aromatase enzyme that is available into skin. Now all this androgen, they will create a microandrogenism environment in the ovary that will lead to follicular atresia. That's why we are finding minute cysts in the ovary. On here side, the estrogen will be increased, so they will have a negative impact on pituitary gland, and because of this negative effect there will be decrease in FSH as compared to LH. There will be increase in ACTH secretion. That will again increase testosterone, means androgens from the adrenal glands also. All our effect is hyperandrogenism. Plus increased LH FSH ratio. This is the overall effect. The side complication of this all metabolic abnormality is there is insulin resistance. Because of this there will be hyperglycemia and obesity. The patient has higher chances of developing diabetes mellitus and other cardiovascular abnormalities in future. Because there is decrease in FSH, the follicular maturation is arrested. That will lead to anovulation. Now, how will diagnose this disease? There is a criteria. When the 2 from the 3 criteria is met, we can clinically diagnose PCOD. 2 criteria from 3. First is an ovulation. There is an evidence of an ovulation. Second is hyperandrogenism. You can confirm clinically by hirsutism. Biochemically by increase the testosterone levels, DHEASs. Polycystic ovaries, you can identify the USG, where you can identify more than 12 follicles of 2 to 9 mh size. Ovarian volume is more than 10 ml. There is an increase in echogenicity of the stroma. So upon these three criteria, we need two to be present to diagnose the PCOD. Now, what kind of investigation we should do it? We should do a hormonal study, as well as ultrasound. In hormonal study, we will study serum testosterone level that is increased in PCOD. Serum androgen binding proteins. Androgen binding proteins means androgen binding globulins. That will be decreased, means there is a increased free androgen available to act on skin and causes all these symptoms of hyperandrogenemia. There is a free androgen index that will increase. FSH is going to be borderline or decreased. LH will be on higher side or increased. As there is ovarian volume is more and there are many follicles there, means the ovarian reserve is more. So AMH, anti-Mullerian hormone, will be increased despite of having infertility. Serum estradiol will be also increased. Insulin circulating in the blood will be also increased. Now, there is again the criteria of metabolic disorder. You can see abdominal obesity is more, the waist circumference is more than 88 centimeters, increased level in triglyceride and LDLs, decreased level of HDL, BP is more than 130/85. All this suggests a metabolic syndrome. Fasting and PP2BS sugar will be on higher side. Now, how we manage this disease? First of all, we need to treat the symptoms of the disease. If there is a menstrual irregularity, then we have to treat the menstrual irregularity first. If there is a main symptom is infertility, we have to treat infertility first. So depending on the main symptoms of the patient, we have to treat this disease rather than treating as norm. If the patient comes with menstrual irregularity, we will prescribe them oral contraceptives that will have a lower dose of contraceptive, lower dose of estrogen and as well as progesterone. If we encounter with hirsutism also, then we can prescribe the oral contraceptives having that kind of progesterone having anti-androgenic property. For example, cryptoacetone or drospirenone, both available as Dinetin or Yasmin. All these kind of OC pills having anti-androgenic activities. So this is prescribed here. On the other hand, DMPA, that is medroxyprogesterone acetate deposit, can also be used in this disease if the patient wants. Our primary goal here is to correct the menstrual irregularity that happens in PCOD. Now, if there is a main symptom or main problem of the patient is infertility, and that is the most common symptom of PCOD. Patient with PCOD comes to you most probably because of the infertility they have. So the reason of the infertility in PCOD is ovulation failure and ovulation. So we will provide ovulation induction. Treatment of choice for ovulation induction. First treatment is clomiphene citrate. It causes 40 to 50% pregnancy rate. Now, what is a clomiphene citrate? Clomiphene citrate is a SERM, selective estrogen receptive modulator. What is the mechanism of action? It is anti-estrogenic at some receptor. Some estrogen receptor it is anti-estrogenic, and at some estrogen receptors it is pro-estrogenic. That's why we are calling it selective. Now, where it is anti-estrogenic? In the pituitary, in the hypothalamus, and at the ovarian estrogen receptors, it is anti-estrogenic. That means it will oppose the estrogen negativity, and that means there will be increase in FSH. So the ratio which was abnormal in PCOD now trying to get normalized. That means increase FSH. Increased FSH will lead to proper maturation of the follicles and further proper ovulation. Now, how we use this? Now, how we use clomiphene citrate? We have to prescribe clomiphene citrate oral tablets of 50 mg starting from third day of menstrual cycle to 5 days. For 5 days means 3 to 8 days of menstrual cycle. The patient has to take 50 mg of clomiphene citrate tablet OD for 5 days. 50 mg is a starting dose. This can be increased if ovulation doesn't happen. It can be increased. Now, how we monitor the response? We monitor by follicular studies, by USG, series of USGs. When we start monitoring on the 12th day of menstrual cycle, we start monitoring by daily USG of the ovaries and monitoring the size of follicles. Now the FSH is normal. That means the recruitment of the follicles, development of the follicles, and selection of the dominant follicle is normal. So we can clearly identify that there is a very dominant follicle is present. That size is 23 to 24 mm. That means there is adequate size of dominant follicle is present, which will be ovulate spontaneously. Listen, we are not using any ovulation agent like LH. It is spontaneous. Now, HMGs can be used for induction also, but it is commonly used when there is a severe resistance to clomiphene citrate and in case of assisted reproductive techniques. Tamoxifen is another SERM that can be also used. Nowadays, new aromatase inhibitor like letrozole came into the market. Letrozole is an aromatase inhibitor that will inhibit estrogen production, and because of decreased estrogen, the FSH will again increase and the ratio will be normalized. There is a very specific space of metformin here. Metformin is called to treat the root cause of PCOD, that is metabolic syndrome. Metformin is an insulin sensitizer here. It increases insulin sensitivity, so it will decrease obesity, it will correct the metabolic abnormalities, and it will definitely help clomiphene citrate to act So when there is a BMI is more than 25 kg per mm 12, we can use metformin, and the dose of metformin is 500 mg OD starting, followed by BD and followed by TID. Now what is the surgical management of this thing? When we do surgical management, when there is a resistance to clomiphene citrate, when the patient don't want these HMGs which have a side effect of ovarian hyperstimulation syndrome, we can offer surgical management, and the surgical management is laparoscopic ovarian drilling. What we do in this technique, we approach the ovary laparoscopically and put 4 to 20 holes of 3 mm to 3 mm size on the anti-mesenteric border of ovaries. What is the advantage of surgical management? There is no risk of multiple pregnancy like in clomiphene citrate. There is no risk of OHSS like in HMGs and even clomiphene citrate. Cyclic monitoring is not required. There are no adhesions because of the laparoscopy technique is so precise. Then there is a very less chance of adhesions. The ovulation rate achieved by this laparoscopic drilling is 53 to 92%, and pregnancy rate is 70 to 80%, very comparable to the clomiphene citrate, even more. Now what is the mechanism of LOD? Basically what it will do, by drilling the ovary, there will be released fluids containing androgens. So in ovary microbe environment, androgen will be decreased, followed by decrease in estrogen and followed by decrease in LH and increase in FSH. Following LOD, the androgen levels decrease by 40 to 50%. Now what can be the complications of all these medications? For example, complication of clomiphene citrate is multiple pregnancy. There is a thickening of cervical mucus, so we are actually increasing the chances of infertility sometimes, but it is always not that. Other disadvantages are hot flushes, dry vagina, scrotomas, dryness of mouth. All these kind of thing can happen. We have to explain the side effects to the patients. When we should avoid clomiphene citrate? In ovarian cyst, pregnancy and any kind of liver disease. These gonadotropins, that is FSH and LH, have a side effect of, very severe side effect of OHSS, ovarian hyperstimulation syndrome. Now what is OHSS? It is very important to know this OHSS. It is a iatrogenic complication induced by drugs. There is a hyperstimulation of ovaries. There is a very increase in ovarian size and estrogen production. The incidence of OHSS is 0.1 to 30%. Now this is a very severe condition. The basic pathology is vascular permeability, increased vascular permeability, that will cause fluid shift from intravascular to extravascular. Because of this, there will be hypovolemia, and the third spaces will be filled with fluid. For example, hydrothorax ascites, edematous, weight gain, all these things will happen. Because of hypovolemia, there is a shock, renal perfusion is decreased, all this kind of thing can happen. There is a classification of OHSS. It's called Schenker-Western classification. It is divided into 3: mild, moderate and severe. In case of mild OHSS, there will be some symptoms like weight gain, abdominal heaviness, swelling, that kind of thing can happen. If you measure the beta estradiol levels, it will be 1000 to 1500. In this case, mild OHSS, the management is at home with fluids proper and observant by family members. The moderate category, when there is a beta estradiol is more than 4000 and the ovary size is more than 6 centimeter, 6 to 12 centimeter, and there is ascites like these things, edema, pleural effusion, all kind of this thing is happening in moderate kind of thing. In this case, we have to hospitalize the patient and monitor the vitals. We can give fluids. Severe OHSS, there is more than 4000 level of 17 beta estradiol. The ovaries will be more than 12 centimeter size. There will be hypovolemia. There will be shock. There is a very severe complication of OHSS, that is thromboembolism. It will be there. We have to hospitalize, put the patient into ICU, monitor all the vitals, give fluids, plasma expanders, prevention of thromboembolism by heparin. We can do it. Now, PCOD is a very common disease and is a very common topic to be asked by the examination. Whatever the exam it is there. So kindly go through it. Thank you.